Thank you very much, Mr. Chairman. So my name is Sharifah Intan. I'm from Hospital Sultan Abaya, Alustar. This is located at the northern region of Malaysia. So after Prof. Wally's mind-blowing research just now, okay, now it's more relaxed session, I think. More of anatomy, because I'm not sure among the crowd how many are really interested doing congenital CT scan, especially in congenital heart disease. Okay. So briefly, this will be my outline. I'll be talking on introduction of pediatric congenital heart scan, some of the indications, scan preparation and technique, and a bit briefly on case review, just about 5 cases, and also the learning points. Okay, I think most of you probably know that congenital heart disease has a different age group. It comprises of from the youngest, which are the newborn, then we have the infant or the children, and even in adults. Okay, so don't think that congenital heart disease only among children. Yeah, even among adults. Adults, you have a group, what you call it as grown up with congenital heart. Usually these are, you can say, more or less the survivors of those congenital heart disease who have had some repair being done to their heart. And sometimes even in adults, we have cases who are incidental and also undiagnosed. So whenever you have a request related to pediatric cardiac CT, what exactly that you should have beforehand for any radiologist who's looking through or vetting through the request. So my advice is you should be well versed a little bit on the history related to the patient, and then any prior operative procedure, for example, any shunts being done, and then at certain palliative operative stages, and also other imaging. And this is quite important because sometimes as radiologists especially, we may not be interested to look so much at the echo, but for whom are doing congenital heart, you should have some idea about what the cardiologists, pediatric cardiologists are talking about. So echocardiography is actually the most common primary imaging modality in congenital heart. So that's the one that we have to be aware. Okay, I purposely put this slide because I think this is very important, because maybe the audience will be interested to ask why do a CT in congenital heart? Why in babies? Why in newborns? So this is paper that discussing on the appropriateness criteria for the use of cardiac CT in congenital heart disease, published by the group Esposito et al. From Italy. So what I just want to highlight is there are some clinical indications which are crucial, especially when you talk about congenital heart, and they did recommend as a strong recommendation to do a cardiac CT. For example, you have cases where patient having isolated congenital coronary artery anomaly. So usually, in order to identify this coronary artery origin, course, angulation, etc., for first diagnosis is strongly recommended. Then we have one of the most commonly presented congenital heart disease, which is tetralogy of Fallot. So usually for first diagnosis, most of the clinician would prefer echo, but then on subsequent follow-up, for example, after certain repair or shunting being done, so these are also recommended to do CT scan. And also in conditions where you have D-loop transposition of great arteries, and in conditions of truncus arteriosus. Even in septal anomalies, for example, you have for first diagnosis in conditions such as ASD or PAPVR or partial anomalous venous return, it's also good to have a CT to be done prior to any procedure. For mediastinal vessel anomaly, for example, in aortic coarctation or aortic arch anomalies, so it's also recommended to do a CT. Even at the level of follow-up of these cases, in case of total anomalous venous return, vascular ring, and pulmonary slings, these are also important to have a CT being done. And also in single ventricle heart disease. There's another paper which is published the US in 2020 by the American Cardiac Association, in which they also recommended some appropriate criteria for multimodality imaging, in which CT was rated high for any complex congenital heart lesion, for coronary imaging or complex vascular anatomy assessment, any pre-procedural evaluation, and also for assessment in case there's any change in clinical status. However, the CT is rated low for condition where you have routine surveillance at relatively short intervals in asymptomatic patients with stable cardiac status, and also patient with mild disease or minimal hemodynamic sequelae after intervention. So this kind of group, usually they will be subjected more into doing echocardiography. Now, this also another slide for especially radiologists. They are always interested to talk about CMR versus cardiac CT. I just want to highlight certain points here. Of course, definitely we have to admit when you do CT scan, you will subject your patient to ionizing radiation. But the advantage is surely you have a relatively shorter scanning time, shorter breath hold in CTA as compared when you do AMR. Of course, the main advantage is no ionizing radiation, but then there will be longer scanning time, especially when you do contrast enhanced MRA, and also the study time will be much longer. So to add to that, now we have the advancement in our CT scan where we have high pitch scanning, fast gantry rotation, and wider detector systems, ECG gating, even automated tube voltage selection and tube current modulation. All these add up to further weightage in the role of CT in pre and also post-operative evaluation for congenital heart. But always be mindful that when you do a pediatric cardiac CT, this will be your issue. You have a wide spectrum of disease, and the disease are complicated, congenital defect, and definitely issues related to high heart rate, because pediatric age heart rate is not the same as adult. And you will anticipate to have motion artifacts related to cardiac and also respiratory motion. And definitely limited patient cooperation. Now this is just showing you my scanner parameter that we're using. Basically, the point that I want to highlight here is that we have advantage of using a tube voltage of 70 kV, which is the most minimum kV present in the market, I think, to date. So for pre-scan patient preparation, this is can be differing from center to center. It's up to you and your center using which protocol. In my center, we still practice fasting at least 4 to 6 hours. The reason being because we are using iodinated contrast. Sometimes we are anticipating if there's any reaction related to that. But of course it differs, and maybe if patients having some allergy, should be having some pre-medication, and of course you need to be aware of the renal function. Now in terms of IV contrast, this is what being recommended by the journals. So I think you can just look through internet, it's quite easily available. Okay, in terms of image acquisition technique, usually the scan range will include whole thorax. Plus, if you have situation where you have infracardiac extension for condition, for example, in Schmita, for example, or collateral supply coming from infradiaphragmatic vessel, so it would be wise to have some infracardiac extension, meaning covering the liver. And for optimum time of acquisition also, it will depend on the hemodynamic status, any previous surgery, and clinical indication. Now, this is especially for radiographers. For when you do planning for contrast monitoring, it's advisable to actually do the planning at the level of a middle of the heart, because whatever you do, whenever you give the bolus contrast, you can simultaneously visualize the cardiac chamber and also descending aorta. Right, this is a commonly asked question to me because I'm doing cardiac CT. So where to exactly place your bolus track? In general, last time when I started practice, the ROI is placed or the marker, you can say in the right heart if you want to assess the pulmonary artery, for example, and the left heart if you want to assess the aorta. But the problem is when you deal with congenital heart, you have both right and left systems involved. So what I can suggest is that we'll try our best to actually to opacify both venous and also arterial structure. And by saying this, actually we prefer to have bolus tract with visual trigger usually located at the left ventricle. This is to my experience regardless of the diagnosis of the case, patient age and also the hemodynamic status. And of course if you beforehand you know that the patient having some extra cardiac conduit, for example in Fontan, you may need to delay your scanning. So this example that what I mentioned just now, we talk about bolus tract visual trigger. So there's the radiographer will press the scanning button whenever there's already optimal or maybe suboptimal. It's just suboptimal LV opacification. But please be careful, because when you do this kind of technique, make sure that your ROI is away from the surrounding area, because sometimes you may wrap the baby with a lot of things, blanket and what so. So sometimes your scanner might detect a different enhancement, not the contrast inside the LV. So this is one example where you have Fontan scanning where there's an extra cardiac conduit. So if you scan too early, you see that there's no contrast inside the conduit. But as you delay further, like in this situation, you have a late arterial and early venous phase, so you have a good opacification. So I just have to go briefly because I think for the sake of time. So radiation dose itself is very important. I would recommend that for the patient having weight less than 35 to be usage of 80 kV. Right, when you have, this is what you need to have a checklist, how to minimize your radiation dose. So always remember, you should put the patient in proper positioning inside your scanner. Preferably no movement. Of course, if they are very small babies, there need to be efforts made for sedation. And use the smallest possible scan range depending on what kind of scan request that you're taking. And like I mentioned, the selection of kV and also collimation and organ dose modulation. So I'll go to case review. This is case number 1. Patient is 1 year 8 months old with TOF, that is tetralogy of Fallot, with LPA. LPA stands for left pulmonary artery osteostenosis, post PDA stenting at day 64 of life. So complicated with fracture of floppy wire during the assessment related to the right heart. This was done by the pediatric cardiologist. But the issue here is that the cardiologist came to us and asking, we wanted to see the stenosis at the LPA because the echo cannot give us that answer. So we proceed doing, because initially I'm not really willing to accept doing this assessment. But because they could not find the answer to that, so we did a CT. And it turned out to be, yes, there's osteostenosis at the LPA. And other structures I'm showing here, these are all within the spectrum of tetralogy of Fallot, which are perimembranous VSD and also overriding aorta. Right. Though this is also when you do the scan, CT scan, definitely you can precisely pinpoint the location of the PDA stent. And also we can visualize the area where the remnant of the fractured floppy wire that has been seen, if there's any local reaction or fibrosis. And the key point here is that we also construct our image using some lung window, because we wanted to know if there's any significant lung changes, and in this situation none. So patient was referred for right heart catheterization again for the stenosis, and eventually got some subsegmental collapse related to the right upper lobe and diagnosed as a right main bronchus Malaysia. So the learning point here is that lowering KV is essential. And you can use a triphasic contrast delivery because, again, by using this technique, you can enhance both right ventricle and also the left ventricle. Right, this is second case, 15 years old, with history of transposition of great artery. Patient had balloon atrial septostomy at day 2 of life with arterial switch. PDA ligation at 2 weeks of life with aortic valve replacement in 2020 due to aortic regurgitation. And there's also a question about suspicion of LPA stenosis during echo. So the CT was requested to assess the LPA branch. Maybe some of you would think this is a really odd anatomy where you have location of the main pulmonary artery just drapes in front of the aorta. So this is what happening during the arterial switch operation. And patient also have had some aortic valve prosthesis being inserted, because as you have this sort of operation being done for neo-aortic regurgitation, most commonly in cases of TGA, patient may have dilated ascending aorta. So just briefly showing you how the operation is being done in arterial switch, where you have the aorta originally connected to the right ventricle, but then for the operation it has been switched. The place for aorta is being placed back to its original position. Right, so home point here is that when you do measurements related to neo, we call it neo MPA, RPA or LPA branches, please use a Z-score for more accurate reporting, because this is based on my experience. Radiologists always like to describe things based on dilated, small or stenosis, but we could not provide any more objective assessment. So my advice is please use a Z-score, and you can have there's a multiple website that you can use for reference. I use parameterz.com and it's easily available, although it is based on the echo. So the learning point here is that echo in this situation cannot adequately assess the LPA stenosis, particularly in gauche cases like this, because of a restricted acoustic window. And CT is definitely the way to go for this patient, and always do an MPR. Right, this is case number 3. It is 2 months old with a 3.4 kg weight and presented with respiratory distress. The echo suspect LPA sling or being absent, and there's collateral from so-called third branch of the aortic arch supplying the left lung. As you can see here, there's the red arrow points to the absence of the left pulmonary artery, and patient also having some abnormal, aberrant left subclavian artery, which is very rare to have retrotracheal. Most of the time they will be retroesophageal in location. And in this case, patient also having systemic collateral supply from the left common carotid artery. And this is diagnosed as a proximal interruption of the left pulmonary artery. And not only that, patient had small PDA coming from the aortic isthmus and dilated RA and LV with strengthening of the interventricular septum. So we are already suspecting there's some form of pulmonary hypertension starting to set in this patient. And of course, since he was presented with respiratory distress, so we had some lung window for reconstruction, and we managed to give the answer that there's no tracheal narrowing or no tracheobronchial arborization abnormalities. And also, okay, I think, yeah. Okay, increased lucency of the left lung, also with relative paucity of the vascular marking. So in this case, I guess the learning point here is that contrast injected from the left lower limb, because we do not want to have so much of a contrast strict artifact coming from upper limb to obscure the pulmonary artery sling. And we are using triphasic in this case, because we first injected only about 2 mils, which is 100% need contrast, and another 2 mils we divided with the saline, and then we scan, the finest push was giving the saline. So when we scan, we are looking at the Hounsfield unit, where the location of the LV. So my learning point here is that proximal interruption is very rare, and CT scan in this situation can be very challenging, because you need to opacify both the pulmonary artery and also collateral, if any. And post-processing is very important, especially for those doing imaging in pediatric. Please do post-processing airway in case you are suspected any vascular ring or sling, because they will give the impact to the clinician. I'll just go through this case because I have I've made them. Until finish, I will talk. Okay, is it okay, Mr. Chairman? Is it okay? It's okay, yeah? Okay, I just continue until it's finished. I'll just stop anywhere if it's, the time. Okay, 28 years old with tricuspid atresia. This patient had a gland shunt. Actually, this is a a situation or a case where we learn from our mistake. This is commonly happening. Whenever you do congenital heart scanning, sometimes this is what happening to us. We only manage to have a very dense contrast, opacifying the BT shunt, the gland shunt, but not the actual cardiac chamber. But then in our second attempt for doing the scan, we further delay the scan by 1 minute, and the result is optimum opacification. So yeah, there are other things to show, but I don't have time. So I think thank you very much for that. Okay, so learning points. Right. Thank you.